Hand hygiene is a very important part of every clinician's examination routine. Hand hygiene is one of the most important measures to prevent the spread of hospital-acquired infections and also the transmission of microorganisms that can cause harm. Today I'm going to demonstrate how to do a hand rub. So first of all, cup your one hand and apply a palmful of product, enough to cover all surfaces of your hands. Then rub your palms together and make sure that the entire surface is covered. The next step is to take the palm of your right hand and apply it to the dorsum of your left hand with fingers interlaced. And do this also with your other hand. Then put your palms together and rub with fingers interlaced. Then make sure that both your thumbs are also cleaned. So give special attention to your left thumb, to your right thumb. Next, interlock your fingers and rotate the back of your fingers on the palm of the opposing hand. Then cup your hand and with the clasp fingers of your other hand, make a rotational movement. Then hold your hands still, do not wave them around until they are completely dry. Then your hands are safe and you can examine your patient.
Mr. Skuman. My name is Mohammed Shafre and I'm part of a group of medical students that will be conducting a cardiovascular examination on you today. Will that be okay?
Yes.
And I'll wash my hands, you don't have to worry about cleanliness. If you're wondering why you're in this position, for a cardiovascular examination we need to keep you at a 45-degree angle and we need to have your neck and chest exposed and there needs to be good light. I'm going to start out with an examination of your general appearance. From your general facial expressions, I don't see any signs of cardiac distress or dyspnea or signs of pain and anxiety related to cardiac disease. So the first step of the cardiac examination is a focused general examination of your body for signs of cardiac illness. We'll start out with your hands. We see no obvious sweaty palms or nicotine staining, which means you're obviously not a smoker. I'm going to now check your nails. First of all, your nail bed is not pale, which means you don't have anemia. And your nails are neither red, which would imply carbon monoxide poisoning or polycythemia. And they're not blue either, which would imply peripheral cyanosis. Also, you don't have any splinter hemorrhages, which means you're not at the risk for infective endocarditis. And lastly, could you just do this for me? So we see a clear diamond shape, which means you don't have clubbing. Lastly, if we just look at your nail bed, your nails are not spoon-shaped, which means you don't have something called koilonychia. Okay, I'll now move on to examining your face. I'm looking for something called mitral facies. I'll now be examining your eyes. Around the eyes, I'll be looking for xanthelasma and I'll be looking for signs of jaundice. I'll now be examining your mouth. I'll look at your lips and if you could stick your tongue out. I'll be checking for signs of central cyanosis as well on your buccal mucosa of jaundice. I'll also be checking your palate to see if it's high and arched, which is another sign of cardiac disease. And it looks like you're all good.
Good morning. My name is Johan Skuman, and with your permission, I would like to examine your arterial pulses. Okay, firstly we have the radial pulse, which is located on the flexor side of the forearm. This pulse can be used to determine rate and rhythm. Next, we have the brachial pulse, which is located in the antecubital fossa, just medial to the biceps tendon. This pulse can be used to determine rate, rhythm, and volume. Thirdly, we have the carotid pulse, which is located medially to the chiromastoid muscle. It can be used to determine rate, rhythm, volume, and character. Then we have the femoral pulse, which is located halfway between the pubic tuberosity and superior iliac crest in the area of the groin. Then it's the popliteal pulse. I position the patient's knee to 120 degrees and I locate the pulse by placing my thumbs on either side of the tibial tuberosity and pressing my fingers into the popliteal fossa against the tibia. Then we have the posterior tibialis, which can be located by placing your index and middle finger just behind the medial malleolus. Lastly, we have the dorsalis pedis, which is located laterally to the extensor hallucis tendon and in line with the interdigital cleft. Okay, after examining your pulses, I found that you have a normal pulse rate, rhythm, volume, and character. And that concludes my examination of the arterial pulses.
Morning, Mr. Skuman. I am Nikita Ginika and I will be measuring your JVP today to find out about the functioning of the right side of your heart. Is that okay?
Yes.
Let's just start by you slowly turning your head to the left, and this movement has to be done slowly to avoid contraction of your sternocleidoid mastoid muscle, which then can obscure the view of your internal jugular vein, which is used to measure your JVP. Now that I've located the sternocleidoid mastoid muscle, we look at the heads of attachment of this muscle, which is the mastoid, the sternal head, and the clavicular head. These three heads of the attachment of the sternocleidoid mastoid muscle forms a triangle that can be used as a landmark to find the internal jugular vein. Internal jugular venous pulsation, which should be located in this triangle, and from my observation it is about there. Now that I have all my landmarks by my sternocleidoid mastoid muscle, I'll be finding my landmark by my sternal angle. So I'll be making a vertical height by my sternal angles. I'll then make a horizontal height that from my highest point of pulsation of my internal jugular vein. And the point of intersection is the measurement of the JVP. In Mr. Skuman's case, it is 2 centimeters, which is below 4 centimeters, and therefore it is considered normal. Thank you, Mr. Skuman.
Mr. Skuman, my name is Simtambeni. I'll be performing now the pericardium examination. So I'll be doing the inspection. So when you look closely to the chest, we see that there is no scars or lesions, which shows that which can show that there's any previous cardiac surgery that we need to be worried about. The head distribution seems normal, especially for a male patient. The shape of the chest looks normal as all the pectoral muscles in place, and the rib cage and everything is fine. The skin color of the chest is also normal. There are no visible vein dilatations which can show any pathology. So I can firmly say that this patient is fine. There's no pathologies. Thank you.
Hi, I'm Palesa van Rooyen, and I'm going to be locating all your anatomical landmarks. First, I'm going to ask you to please turn your head to your left, and this is your sternocleidomastoid muscle. Please turn your head back, and here in the middle we'll locate our suprasternal notch. Okay, the suprasternal notch, you're going to move down to locate the sternal angle, which we're going to mark over there. Then you're going to move parasternally to the left. You will find the second rib, and just below that the second intercostal space, where we'll locate our pulmonary area. We're going to mark as there. You suprasternal notch, sternal angle, parasternally to the right. There you find your second rib. And then in the second intercostal space, you locate your aortic area, which we're going to mark as over there. Suprasternal notch, sternal angle, second rib, second intercostal space, third rib, third intercostal space, fourth rib, fourth intercostal space. Parasternal to that, we'll locate our tricuspid area. Then we're going to move fifth rib, fifth intercostal space, clavicle. Then you locate your mid-clavicular line, which is located there. You move down, and here you should locate your mitral valve, which is 1 centimeter medial to your midclavicular area, and here in your mitral valve area you should locate your apex beat as well. Then here we have our anterior axillary line.
Good day, Mr. Shoffre. I'm Michaela. I'll be palpating your apex beat today. Will that be okay? Okay. So the apex beat can be defined as the most lateral and inferior point or border of the heart, where your cardiac impulse is visible or palpable. Placing the flat of my hand fairly laterally and inferiorly along the 5th intercostal space, as not to miss any pathology, moving medially to feel for the apex beat. I'll locate the beat with my index finger, make a mark, and confirm its position, starting from the suprasternal notch, moving down the manubrium to find the sternal angle just below that, just below the 2nd rib. I'll locate the 2nd intercostal space, and then I'll count down each rib and intercostal space along the midclavicular line. 1 centimeter medial to the midclavicular line is normally where one will find the apex beat or the point of maximum impulse. Character or quality of the apex beat is normal as it gently lifts my palpating fingers. Now to palpate for any heaves and thrills. So I'm placing the heel of my hand along the left parasternally, and a heave is present if my fingers are gently lifted off the chest with each systole. No heave present. Now to feel for any thrills over each of the 4 heart valve areas. No thrills present. Thank you, Mr. Shoffre.
Thank you.
Good morning, Mr. Skuman. My name is Ilham Khan and I'll be doing the percussion of the cardiovascular system. Is it okay if I demonstrate how to do this?
Yes.
Okay, thank you.
So first I identify the sternal notch, moving down to find your sternal angle, and then I move across to your 2nd intercostal space, and then I percuss until the percussion note goes from resonant to dull, and I use the midclavicular line as the margin at which I percuss. So resonant, 4th intercostal space, slightly dull, then and that represents the superior border of the heart. Then to determine the lateral border of the heart, we percuss from the mid-axillary line towards the immediately towards the sternum. Okay. Resonant, dull. If the borders were more than 10.5 centimeters apart, then that would indicate cardiomegaly. I'm quite satisfied that everything is normal, and yes, thank you.
My name is Mr. Skuman. My name is Noshina, and I will be listening to your heart sounds today. Is that okay? First, to identify the sternal notch, and we'll move downwards towards the angle of Louis. We'll move across towards the right of the sternal border, where we'll have the 2nd rib, and just below we'll have the 2nd intercostal space, and this is where we will find the aortic area. So as we move across towards the left of the sternal border in the 2nd intercostal space, we'll find the pulmonary area. We then move downwards. We'll first find the 3rd intercostal space and then the 4th intercostal space. At the 4th intercostal space, we will find the tricuspid area. Then you move across in the 4th intercostal space, slightly medial to the midclavicular line, which is found over here, where you will find the mitral area. Everything sounds very normal, Mr. Skuman. Thank you.
Hi sir, my name is Zaria Ibrahim. I would like to listen to your normal heart sounds. Is that okay?
Yes.
Okay, so first of all, we call normal heart sounds S1 and S2. S1 is the first heart sound. It's heard best over the mitral area. and it is heard as a loud, low-pitched and longer sound than S2. This sound is heard due to the closure of your mitral and tricuspid valves. It coincides with the start of systole or ventricular contraction. Okay, so it synchronizes with your radial pulse. So when I listen to your S1, I'm going to simultaneously take your radial pulse just to make sure that they are synchronized. Okay, perfect. And now your S2, that is at best over your aortic area as a shorter, higher pitched sound than S1, and it coincides with the end of systole or ventricular relaxation. It signifies the closure of the aortic and pulmonary valves. Okay, so I need to listen to all of them together. Okay, perfect. Thank you.